This is we'll be talking on post-renal transplant malignancies. Now, as Suraj rightly pointed out, as we venture into more and more aggressive forms of therapy, again you tend to encounter more and more problems. Earlier, when we had few immunosuppressants and with the less potency, we encountered more of rejections. Now we encounter the rejection rates have come down, especially acute rejections have come down drastically, but the complications due to immunosuppression are a problem. So renal transplant surgery offers patients with ESRD a longer life expectancy and better quality of life due to modern advances in immunosuppressive therapies. Immunosuppressive therapy prevents graft rejection and makes the transplanted organ last longer. Nonetheless, lifelong immunosuppression comes at a cost of post-transplant malignancies, which have become a leading cause of morbidity in this group. So cancer is the second leading cause of death after cardiovascular disease in post-transplant patients. And the incidence is said to be increased 2 to 3-fold compared to the general population. Skin cancers are the most common malignancy, seen in nearly 50% of post-transplant recipients. And post-transplant lymphoproliferative disorder, PTLD, is the second most common malignancy in solid organ transplant recipients. Now, the standard incidence and mortality ratio. So, ratio when we take the incidence of malignancy, especially the skin cancers, the numbers are more. So, incidence is more in skin cancers, especially Kaposi sarcoma, which we rarely encounter in our population, and non-melanotic skin cancers. And next is non-Hodgkin's lymphoma. So, whereas the mortality is most commonly encountered in cases of non-Hodgkin's NHL and renal cell carcinomas. The standard incidence ratio compared to the general population. So, it is almost in case of non-melanoma skin cancers, post-transplant lymphoproliferative disorder, renal cell carcinoma, Kaposi sarcoma is all, it's more than 5 times that compared to the general population. Whereas it is 2 to 5 in thyroid cancer, melanoma, multiple myeloma, and leukemia. The incidence of breast cancer, prostate cancer, and lung cancer are less than double that of the general population. Now, how these malignancies come? So, malignancies after transplant can develop in 3 different ways. One is de-novo occurrence in the recipient. That is the most common type. Then recurrent malignancy in the recipient. So, any patient with the malignancy, we wait for a time and then we transplant with immunosuppression, both induction and maintenance immunosuppression. Certain malignancies tend to recur. And rarely transmission of malignancy from the donor also possible. But we rarely take donors with the malignancies. But especially in case of deceased donor, when the deceased donor program is active, this is a problem that we may encounter. That is a transmission of malignancy from the donor. So what is the long-term de-novo malignancies, the long-term retrospective analysis? That is they have a group of 1,417 patients with a diagnosis of malignancies were identified, and a matched control group was assigned to the kidney transplant recipients with the post-transplant malignancies. 179 malignancies after transplantation were found in 154 patients. So certain patients have more than one malignancy. The overall incidence of de-novo malignancies was 1% per year post-transplant. Now, de-novo malignancies. After kidney transplantation, de-novo malignancies remain a significant issue. To enhance long-term results, prevention and cancer screening must be more customized and intensified. In a retrospective analysis, 143 patients with medical histories of pre-transplant renal cancer, clear cell and papillary cancers, 13 experienced cancer recurrence after kidney transplantation. The mean delay in recurrence was plus or minus 2.3 years post-transplantation. And the risk of recurrence was higher in patients with the clear cell carcinoma, when though it was both clear cell and papillary cancers were compared, more recurrence was seen in clear cell carcinoma. Donor cancers, a total of 69 studies with 104 donors transmitted cancers were identified. Frequency of malignancy transmission was higher in renal cell cancers, melanoma, lymphoma, and lung cancers in that order. Patients with melanoma and lung cancers had worse prognosis, with less than 50% of recipients surviving after 24 months from transplantation. This is the Kaplan-Meier curve showing the survival. So the recipients who developed donor-transmitted renal cancer had the best long-term cancer survival outcomes. This finding supports the current recommendations for rejecting organs from donors with a history of melanoma and lung cancer, but may consider the use of donor kidneys with a history of small and incidental RCCs. So, different malignancies, the recommendation is different for to consider as a donor. So, those who had the donors who had a history of malignancies, the type of malignancies, that's all, that is important. And so the wait time, we'll come to the wait times for different different cancers. So the wait times also differ. In one is the stage of malignancy, second the type of malignancy. All these things will come to it. So these are the risk categories. So benign tumors, it's only standard recommendation, no significant risk. Then risk category is minimal in case of these cancers, especially skin cancer, basal cell and squamous cell, non-melanoma skin cancer in situ, cerebral carcinoma in situ, non-invasive papillary carcinoma, and resected solitary RCC, that is less than 1 centimeters. So these are the malignancies which you may consider as a minimal risk, and it should be the transmission risk estimate is less than 0.1%. So the recommendation is clinical judgment with the informed consent. So all these cases you'll have to have informed consent before you take any patient with the malignancies. So so the low risk category is the low grade CNS tumor. Again, CNS tumor with the chance of metastasis is less in case of low grade CNS tumors. So, and resected solitary RCC, that is between 1 to 4 centimeters. Treated non-CNS malignancy more than 5 years prior with more than 99% probability of cure. That is the catch there. So more than 99% probability of cure. You wait for 5 years, and the probability, if it is more than 99% cure, then you can take in the recommendation. The transmission risk is said to be 0.1 to 1%, and recommendation is use in recipient at significant risk without transplant with informed consent. So somebody who is in need for a transplant, especially somebody who has no access, probably no, they are the candidates for a immediate transplant. Then intermediate risk, breast or colon carcinoma in situ, resected solitary RCC 4 to 7 centimeters, treated CNS non-CNS malignancy more than 5 years with a prior with a 90 to 99% probability of cure. So those are intermediate risk, and you had to, the transmission risk is estimated to be 1 in 10%. Generally, so in these cases, it is generally not recommended. So, and the high risk category, probably it's contraindicated. Use is not recommended, especially the malignant melanoma, breast, colon or lung cancer, RCC more than 7 centimeters, high-grade CNS malignancy, leukemia, lymphoma, or sarcoma. Probably this all hematological malignancies comes under this group, leukemia, lymphoma, or sarcoma. So, and all high-grade tumors also comes in the high-grade category. So probably we are left with the skin cancers and in situ cervical and non-invasive papillary carcinoma and resected solitary RCC less than 1 centimeter. So in those cases, probably we consider, especially in cases of a deceased donor program. So viruses associated with the post-transplant malignancies these are a major concern, especially with the use of immunosuppressive agents. The viral replication. So the most important being Epstein-Barr virus, which is a post-transplant, which is associated with the post-transplant lymphoproliferative disorder and smooth muscle tumors. And human papillomavirus is associated with squamous cell carcinoma, HHV8, Kaposi sarcoma, and multiple myeloma, HIV, and plasmablastic lymphoma, Merkel cell carcinoma, HCV, hepatocellular carcinoma, and plasma cell neoplasm. Because earlier we had many cases of HCV positive recipients who had been put on immunosuppression. Already HCV has an increased incidence of malignancy, hepatocellular carcinoma. Once you immunosuppress, the chance of developing hepatocellular carcinoma is still high. And BK polyoma virus urothelial associated with urothelial carcinoma. What are the risk factors for development of post-transplant malignancies? As you know, mostly we it is classified into 3 different groups. The risk factors, that is a patient-related. Recipient age, especially in the general population, when the age goes up, the incidence of malignancies are also higher. Then any previous cancer or treated cancer, then there's a chance of recurrence. Then sun exposure, viral infections and duration of viral infection like HCV or EBV, duration of dialysis also said to be another risk factor. Transplant-related factors are donor transmission, then donor type, and whether it is cadaveric or live-related. Then incidence of rejection is also said, because rejection, you tend to immunosuppress the patient more. Medication-related, net immunosuppression, and that is induction therapy and maintenance therapy both. So here again, induction therapy, we use different types of agents for induction therapy. So which has a difference in the incidence of malignancies. So how this immunosuppression causes, what is the pathogenesis behind it? So immunosuppression, there's an altered immunity and immune phenotype. The one is the reduced cell numbers and function of both dendritic cells and natural killer NK cells. So so once their number is reduced, the tumor surveillance, just like it prevents the infection rates as well as the incidence of tumors. So tumor surveillance also decrease as the NK cells and dendritic cells. And on the other hand, when the CD8 T cells increase in immunosuppressant T cells, again this will cause decrease in viral immunity and tumor. And T regulatory cells increase in T regulatory cell numbers, again decrease in the anti-tumor response. So this all ultimately lead to post-transplant or augmented incidence of post-transplant malignancies. So then we come to the especially calcineurin inhibitors. So calcineurin inhibitors, both tacrolimus and cyclosporin, both can is associated with increased incidence of malignancy. So it will cause increased expression of cytokines, the growth factors. So there is increased VEGF, increased TGF beta, the increased RS signaling, increased interleukin 6. So these all and decrease in DNA repair. So these are all in one way or the other, it will increase the incidence of cancer, like increase the angiogenesis, increase in tumor growth, and increase and again increase RCC and increase in the incidence of increased B cell proliferation lead to increased PTLD. So both by the response of the increase in the incidence of the response of the interleukins, expression of the growth factors, so, this will increase the incidence of tumors. Now, coming to the each immunosuppressive agents. Now, coming to calcineurin inhibitors, these are the important factors which I have already explained, like production of TGF beta, production of VEGF, and production of interleukin 6. And so these all will increase the or promote the oncogenesis or the carcinogenesis in these patients. Azathioprine is said to have as a role as intercalation at the DNA level, inhibiting repair and splicing and eliciting codon misreads. Mycophenolate to an anti-proliferative effect on leukemia and solid tumor cells, and inhibition of adhesion molecules, then suppressed glycosylation of and expression of several adhesion molecules, and inhibition of adhesion of colon and colon adenocarcinoma cells and endothelial cells. So there's mycophenolate. One side it will increase the the incidence of viral diseases like Epstein-Barr virus, CMV, BK virus. All these either virus transmission or virus multiplication is enhanced with the mycophenolate mofetil. So these are oncogenic viruses, and oncogenic viruses again. So so mycophenolate is said to have this especially virus-induced tumorigenesis or oncogenesis in this patient. On the other hand, mTOR inhibitors. mTOR inhibitors is the incidence of malignancy is less because it will inhibit. The direct anti-tumor effect by inhibition of mTOR pathway, and it will inhibit angiogenesis. The calcineurin inhibitors, it will increase angiogenesis, whereas mTOR inhibitors, it will inhibit angiogenesis. So, and there are various methods by which the mTOR inhibitors is probably both. It has antiviral properties and it has it will inhibit or it will inhibitory effect on the tumor formation or oncogenesis. Now another important question is, when there is an increased incidence of malignancies, we should we should have a screening or the surveillance of for cancer. That is especially those the malignancies which are increased in number or the increased incidence. We have to screen for those malignancies at least on a periodic basis. So what is recommended is breast, the annual or biennial mammography for all women. Then gastric and colorectal annual fiber optic scopy or 3-yearly esophagoduodenoscopy and flexible sigmoidoscopy for individuals older than 50 years and with a positive family history. So in this case, those cases, we'll have to screen for colorectal and gastric malignancies. Cervical annual cytological cervical cancer screening and pelvic examination. Probably that is one of the easiest to carry out. Prostate annual digital rectal examination, PSA measurement. That is also those who are older than 40 years. That's also feasible in almost all. Hepatocellular carcinoma, alpha fetoprotein and ultrasound performed every 6 months in high-risk individuals, especially in patients with HCV. Skin, monthly self-skin examination, total body skin examination every 12 months by expert physician or and dermatologist. Probably that is also because the skin cancers are said to be most common. Probably not in our population. We come to our statistics. So, but especially in the Western world, skin malignancies are very common. And renal ultrasonography of the native kidneys every 6 to 12 months. PTLD virus related. So viral nucleic acid testing. So for EBV until 6 months, every month for until 6 months post-transplant, and every 6 to 12 months thereafter. So because the PTLD is said to be common in usually in the immediate post-transplant period. So usually in less than 2 years post-transplant. That is the usual time of occurrence of PTLD. So probably that colorectal and gastric every 3 years to undergo a colonoscopy and esophagoduodenoscopy, that will be a little difficult, cumbersome, but all other screening methods are easily performed, can be easily performed. Now, decisions regarding waiting time should be individualized, and it should be explained to all patients with a history of cancer, and that they are at increased risk of de-novo malignancy post-transplantation. And recommended waiting periods before transplantation do not guarantee no recurrence of malignancy after transplantation. These are two things where probably we need to have an informed consent before transplantation. So de-novo transplant. So when we give informed consent, when we take informed consent, probably these two aspects, malignancy, the increased incidence of malignancy also needs to be stressed. Now, recommendation for absolute contraindication for transplantation is uncontrolled or untreated malignancy. Untreated malignancy you cannot. Multiple myeloma, advanced breast cancer, stage 3 and 4 or 4, colorectal cancer, stage D, and advanced prostate cancer, grade 4, 5. So where no waiting time is required. So superficial bladder cancers, non-metastatic basal cell carcinoma, prostatic cancer, microscopic, focal microscopic low grade, that is Gleason square grade less than 3, and incidentally discovered the T1 renal cell carcinoma with no suspicious histological features. Then monoclonal gammopathy of undetermined significance. So these are the recommendations. So where we do not wait, because we don't expect a distant metastasis in these patients. Probably either it's a localized form of malignancy where you can just remove the malignancy, and the chance of recurrence is just like non-metastatic basal cell carcinoma. If it is confined to the skin only, you can probably that is the all those cancers we need not wait. 2 years waiting time. So after treatment, that is all this is after treatment. Invasive bladder cancer, the in situ breast cancer, localized cervical cancer, Duke stage A and B1 colorectal cancer, lung cancer, prostatic cancer, testicular cancer, thyroid cancer, Hodgkin's lymphoma, non-Hodgkin's lymphoma, post-transplant lymphoproliferative disorder, and leukemia. Probably all this hematological malignancies is said to be 2 years waiting time, and in situ melanoma. 5 years waiting time for stage 2 breast cancer, extensive cervical cancer, and in situ cancer of the uterus, colorectal cancer stage C, melanoma, large or invasive or symptomatic renal cell carcinoma. So you have to wait for a period of 5 years. Now, management of cancer. So, how to manage the immunosuppression? Immunosuppression, lowering the dose of immunosuppression, modification and discontinuation of immunosuppression therapy in certain cases, and surgical excision of the tumor, radiation, and chemotherapy. So, limiting the skin exposure, frequent dermatological screening, and prophylactic retinoids. So, therapies for PTLD. PTLD is one of the common malignancies we encounter post-transplant. One is dose reduction. So again, how much to reduce? What all immunosuppressants to discontinue? These are all the questions that's always asked. So you don't get a definitive recommendation as such for how much immunosuppression to reduce and which all things to reduce. These are all you don't get a recommendation. So in PTLD, dose reduction or complete discontinuation of immunosuppression is first line, and immunotherapy and chemotherapy. So what was advised earlier, it was a CHOP or R-CHOP, that is a usual chemotherapies for even for all lymphomas, and a median survival of 27 months were achieved with a no transplant rejection observed when the CHOP chemotherapy regimen was combined with the reduced immunosuppression. Whereas with the rituximab is the common agent used now for most of the lymphomas, and rituximab has also been tried and resulted in remission 44 to 65% of patients with PTLD. So assessing the impact of changes in immunosuppression on patient survival and graft function. So data from 110 patients were analyzed. So a median percent dose reduction of each immunosuppression. So mycophenolate is tacrolimus, cyclosporin, and mycophenolate. These are the drugs which we modify the immunosuppressive. And tacrolimus, a median percent dose reduction was said to be from median was 60%, cyclosporin was 100%, and mycophenolate was again 50 to 100%. So the cyclosporin was almost 100% discontinued in those studies. Whereas tacrolimus was reduced to 60%, and mycophenolate. What we follow is if it is a PTLD, we just come off mycophenolate, and patient will be put on rituximab. So rituximab will take care of mostly the rejection factor, and we reduce the TAC by almost 50%. So 50% of TAC and steroid to continue, and the rituximab. And once the patient is off the rituximab treatment, we may restart or we may increase the dose of tacrolimus, and that is on a case-to-case basis, individualized. But mostly, once it is diagnosed, we reduce the tacrolimus by 50%, and we come off mycophenolate. Assessing the impact of changes in immunosuppression on patient survival and graft function. Immunosuppression dose adjustment was not statistically associated with the mortality risk. Chemotherapy was the only factor that was significantly related to mortality. And immunosuppressive reduction was not statistically associated with the worsening graft function or graft survival. In subgroup analysis, with the reduction of both mycophenolate and calcineurin inhibitors was associated with the graft worsening graft function and lower graft survival. So when you reduce the immunosuppressive agents, there was a worsening of graft function observed in the and a lower graft survival. So the study shows no difference in mortality and graft survival outcomes between reduction or no reduction of immunosuppression in kidney transplant recipients diagnosed with cancer. So the graft survival, mortality and graft survival between reduction and no reduction in immunosuppression. But we usually we reduce the immunosuppression because again, when we treat with either with the CHOP or either with the rituximab, there is an additional immunosuppression which can amount to increase the incidence of infections. And as cancer screening should be highlighted as crucial due to the high mortality and morbidity rates cancer causes in kidney transplant recipients. So now let me come to our experience in Namrata. So of the total 830 cases of renal transplant recipient, 80 recipients, that is 2.2%, were diagnosed with malignancy. 9 out of 18 patients were males. The mean age at diagnosis was 41 years, and the mean duration of recurrence of malignancy following post-transplant was 38 months. So almost 3 years post-transplant. Nine patients developed solid organ tumor, and nine patients developed post-transplant lymphoproliferative disorders. Of the 9 cases of solid organ tumors, 4 had squamous cell carcinoma of the tongue, followed by 1 case each of adenocarcinoma of pancreas, squamous cell carcinoma of the lung, and squamous cell carcinoma of the vulva. 2 patients had carcinoma of the colon, out of which 1 was combined liver and kidney transplant recipient. 8 out of 18 patients succumbed to their malignancy, a mortality rate of 44%. So these are our, so if PTLD, we had the highest, so almost 9%, that is a 50%, followed by squamous cell carcinoma of the tongue. So other squamous cell carcinoma of the lung and squamous cell carcinoma of the vulva, these are the 2, again, that adds to the squamous cell carcinoma. So types of malignancies, most common being the PTLD in 50% of the cases. Now, on this, this is 33% were as an induction agent they had the ATG, 22.2% had the Basiliximab, and 44.4% no induction. Only when you look at it, this is looking at somebody may again may find something with no induction, 44% had malignancies. So our transplant program in the beginning from 2000 to 2010, we didn't have any, we have not used any agents as induction therapy. So that was the period. So those patients probably had malignancies later in their life. Almost 50% of the transplant recipients did not have any induction agents. Whereas this 33% we of late we use ATG as an induction agent, and PTLD we have seen in of the 9, 7 patients in this group, ATG group. Now, again, most of the patients in ATG induction group developed malignancy within 12 months post-transplant. 3 PTLD and 1 carcinoma CA tongue. None of the patients with a no induction group developed malignancy within 1 year of transplant. So how was the presentations of PTLD? 3 patients had pancytopenia as the presentation. 1 patient had developed tonsil swelling. It was he was operated for a quinsy. So, but the ulcer, it was an IND, but the ulcer, instead of healing, it has grown in size because it had become a big ulcer. And then repeat biopsy from the tonsils showed it's a PTLD. And PTLD, other 4 patients are presented with abdominal pain. And when they had undergone scopy, and from the intestine, biopsy was taken from the gastric gastric mucosa, so it was found to be PTL. And one surprising, one patient presented with the eye swelling of the eye, and so it was exophthalmos and proportion of the eye. So initially we thought it was something like a fungal infection or tuberculosis. We did repeated biopsy, and I think it was a fourth biopsy yielded lymphoma. So that was so patient had been treated with treated with antifungal agents, antibiotics, but it was not settling. Of the 9 cases of PTLD, 6 had expired, making PTLD the most fatal post-transplant malignancy in our setting. 3 patients had worsening of graft function at the time of diagnosis of PTLD, out of which 2 patients developed graft failure and went on to have a second transplant subsequently. Of the 830 post-kidney transplant cases reviewed in the single center retrospective study, the incidence of malignancy was 2.2. And at our center, there was a prevalence of PTLD as a major type of post-transplant malignancy. And so this may represent either an ethnic predisposition to this disease or some environmental or immunological risk factors. So I would like to know what is from US centers around Cochin or Kerala. So what is the type of malignancies? So coming to the take-home points, cancer is an important outcome after kidney transplantation because it is the second leading cause of death in most Western countries. The excess risk of cancer after transplantation is approximately 2 to 3 times than the general population. Once cancer develops, outcomes are generally poor, and risk factors for skin cancers are ultraviolet radiation, human papillomavirus, and use of cyclosporin and azathioprine. Numerous viral infections have been associated with the transplant-related malignancies. For potential kidney transplant recipients with a history of cancer, a waiting time period of 2 to 5 years after cancer treatments is generally recommended before kidney transplantation. Renal transplant recipients should be screened for cancer regularly after transplantation to enable early intervention when necessary. And in transplant recipients who develop cancer, treatment strategies should include careful reduction of immunosuppression and the use of standard cancer treatments, with the consideration given to drug dosing, drug-to-drug interaction, the potential impact of chemotherapy agents on graft function. Thank you.